Okay, thank you very much for inviting me to do this talk. I have labeled it obstructive sleep apnea, the worst comorbidity to have with cardiac disease. And it's the worst comorbidity because nobody knows they have it unless they have a bed partner that complains of it. And very few doctors actually ask about it. And so it's a hidden disease that does affect cardiac disease very much, and we need to be able to find it. So thank you for that introduction, because it did explain a lot about sleep apnea. So let me start. There we go. So the outline really is we're going to be talking about which patients are most likely to have sleep apnea, a bit about the pathophysiology, and then really looking at the consequences of sleep apnea, which I think are more important, and then briefly looking at treating sleep apnea. The problem with sleep apnea is there's now so much information on it that we can talk for hours and hours and hours about it. So generally, most doctors have never heard about sleep apnea at med school, not even as, certainly not as part of their undergraduate training, but often not even as a postgraduate training. So despite that, obstructive sleep apnea is still an important problem. So there's a study done by Benjafield in 2019 in The Lancet, where they did a modeling study for every country in the world as to what they predicted the prevalence of obstructive sleep apnea was. The data for Mauritius says that in patients aged between 30 and 69 years old, that approximately 26% of the population has an AHI more than 15, and that would put them in the moderate category. So moderate to severe apnea, 26% of the population. There's very often no formal teaching, and sleep, and then part of the reason for that is sleep is one of the very few multidisciplinary fields. There's not a single specialty that doesn't have some connection to sleep or some reason why they shouldn't know about sleep medicine. So if we talk about obstructive sleep apnea, I think we all know the symptoms. So heavy snoring, gasps and pauses in breathing, restlessness, excessive daytime sleepiness, but there's a whole lot of other symptoms which may be connected. So things like headaches, particularly nocturnal headaches, nocturnal polyuria, hypertension, gastroesophageal reflux, impotence and lack of libido. All of those are connected and can be indicators of obstructive sleep apnea. But it's really important that in other patients, so when we think about traditional symptoms, we think about patients who sleep through the night, wake up feeling very tired, and then are sleepy during the day. But in women, those symptoms are not necessarily like that. They tend to have lower scores on the Epworth Sleepiness Scale, and we'll look at that in a moment. They often present with different symptoms such as insomnia, nightmares, depression, palpitations, so waking up with palpitations. And 40% of women who have moderate sleep apnea do not report any of the classic sleep apnea symptoms. And so, sorry. Yes.
Your slides. Can you share the screen?
I am sharing the screen. Do you want me to try again?
Yeah, please give us.
Sure. I'll stop sharing and I will share again. So let me try share again. Sure. No problem.
Okay, now we're starting. Thank you.
Have you got it now?
Yes.
Okay, so I'm just going to go back a few just to show you this data from Mauritius. So here's the data for Mauritius, and here is the number of an AHI greater than 15, which is 26%. So really quite a significant. The one for South Africa is 23%, and most countries, in fact, sit over the 20%. Okay, so let me just move on. So talking about women who may present with different symptoms, and certainly, 4 out of 10 women are not going to report any of the classic sleep apnea symptoms. So again, may present with depression, may present with insomnia, waking up at night with palpitations. And the symptom load is different in women. So at a lower AHI, they're more likely to have symptoms, but obviously not the traditional ones. Many children also have sleep apnea, particularly children with Down syndrome because of the large tongue relative to the size of the mouth. So more than 50% of children with Down syndrome are likely to have sleep apnea. So women will tend to present with different symptoms, but so will men. So only 60% of patients with sleep apnea have the traditional excessive daytime sleepiness, which is linked to cardiovascular risk. Older patients also present differently. They have less sleepiness during the day, and they present with enuresis, cognitive dysfunction, and mood impairments. male symptoms in the phenotype. So these are statistics that I often talk to patients about, that only 42% of patients, of male patients with sleep apnea in Iceland, only 42% present with excessive daytime sleepiness, a third present with disturbed sleep or insomnia, and 25% are minimally symptomatic, in that even if you treat severe sleep apnea in them, they do not get any resolution. There are very few symptoms that they complain of. I've certainly had patients who swear they have no symptoms whatsoever, no daytime sleepiness, wake up feeling fine, even with an apnea index over 50. So one of the studies said that there were really two types of patients, and that's middle-aged obese women with marked insomnia, depression, and other comorbidities. And then another group of older obese men with typical nocturnal and diurnal symptoms and a marked comorbidity burden. I think what's really important is the comorbidity burden, that these are patients who tend to have other disorders as well, not just sleep apnea. So it's much easier, rather than think of sleep apnea as another disorder to add to your list of the disorders that you need to look for, is to look for sleep apnea in those patients in which it is likely to be there. So the high prevalence disorders for sleep apnea are atrial fibrillation. So half of those patients are likely to have sleep apnea. In metabolic disorders, it's up to 60% of every patient who has type 2 diabetes. Resistant hypertension, 80% and over. Just hypertension on its own, 40%. The other cardiovascular disease, 30 to 60%. And so it's easier to target these patients and look for sleep apnea in these patients than it is to just pick random patients to see if they might have sleep apnea. Obviously, if patients come in and they say they're snoring and they wake up tired in the morning and they have excessive daytime sleepiness, then obviously those would be patients that we were likely to go and look for sleep apnea. So how do we find these patients? A very easy questionnaire to use as a screen is the Stop Bang. And there are 4 questions in the Stop. And that is, do you snore loudly? Or do you often feel tired, fatigued, or sleepy? Has anyone observed you stop breathing during your sleep? Patients who don't have a bed partner, the question is, have you ever woken up coughing, choking, some kind of respiratory issues in the middle of the night? And then, do you have or are you being treated for high blood pressure? That's the Stop. The Bang is more examination based. So is the BMI over 30? Is age over 50? Neck circumference, is it over 43 centimeters in men and 41 centimeters for women? And are you male? And you can see that if you are just an obese male, that pretty much all 4 of these are likely to be yes. And then if you just snore, you hit the 5 out of 8. And 5 out of 8 in men and 4 out of 7 in women, there's an 80% chance that you will find apnea. It doesn't speak to the severity of apnea, so it might be mild sleep apnea, but 80% is a very high hit rate for any kind of screening questionnaire. So it's a very good predictor of whether you're likely to find sleep apnea. As far as daytime consequences are concerned, the one we generally tend to use is look for sleepiness in the Epworth Sleepiness Scale. This is a scale that's been around since 1987. We still use it. And it asks, how likely are you to doze off or fall asleep in the following situations? If you score more than 10, so the total is 24. If you score more than 10, that is considered to be pathological sleepiness or important sleepiness or relevant sleepiness. And we would look for a sleep disorder in those patients. As long as they're getting enough sleep at night. The thing with insomnia, you'd kind of go, well, if you're not getting enough sleep, do you get sleepy during the day? Not really. So most insomniacs are not sleepy. They're fatigued, but they're not sleepy. So a sleepiness during the day usually indicates sleep apnea or periodic limb movements, which is related to restless leg syndrome. So the guidelines for sleep testing, what do you do at that point? These are our society guidelines, which are based on the American guidelines, the Australasian guidelines, and the European guidelines. And the difference with our guidelines is we have included all sleep disorders into one set of guidelines, whereas most of the international guidelines just speak to sleep apnea. So if patients have clear signs and symptoms that are consistent with moderate to severe apnea, all the guidelines would recommend that you do a home-based apnea screening test with a technically adequate device and a comprehensive report. So do a home test because the chance of you finding a positive result is actually quite high. If, however, there are indications of sleep disorders apart from moderate to severe apnea, then we would go for a full polysomnogram, which includes EEG, EOGs, and EMGs, the more traditional type of sleep studies. But the home-based testing is the way to go, certainly if you're just looking for apnea. So when we measure respiration, usually this is the kind of measurement that we would do on some of the home testing devices, certainly on the full polysomnogram devices. We used to use thermocouples, and that would be literally looking at temperature differences, as in cold air breathing in and hot air breathing out. Most people would now use nasal pressure. So we use a nasal cannula, the same cannula they use for delivering oxygen. And it's measuring pressure, as in low pressure breathing out, lower pressure breathing in and higher pressure breathing out. And then usually we monitor chest movement and abdominal movement. And classically, what we would get with apnea is big breaths occurring and then a flattening of the nasal pressure, i.e. no airflow is occurring with consistent respiratory effort. So the important thing about sleep apnea, and the first thing to explain to patients about sleep apnea, is that it is not that they stop breathing at night. The respiratory effort continues, the brain continues to try and exert the pressures to create respiration, but there is a lack of flow. So there's a lack of airflow, and that is due to collapse of the pharyngeal area. So you would see this drop in airflow with breathing, and that would be an obstructive sleep apnea. If you have a lack of flow with a lack of respiratory effort, then that is a central sleep apnea. Central sleep apnea on its own is extremely rare. Less than 1% of patients who are go through a sleep laboratory will you find classic central sleep apnea. In Johannesburg, we find quite a few patients with central apnea mixed with obstructive apnea, and that is because of the altitude that we're at. So generally, so I was asked to talk about the WatchPat as a way to measure do apnea screening. It's the one that I use. So what it does is it measures arterial pulse volume changes in the finger, and it looks at vasoconstriction and vasodilation, looks mainly at the response to apneas, the cardiac response to apneas. And it's quite a big jump intellectually to go from a system that directly measures flow and respiratory effort to a system that doesn't measure that at all and measures something else. So it took me quite a while to kind of trust it. I kind of want to say that, but it works extremely well. And what's nice about it, it gives very good data because the patients who take it home, it's very easy for them to apply at home and gives us really good data. So it's really based on, part of the algorithm is based on the fact that at the end of the apnea, there's an arousal from sleep with a surge of noradrenaline, which creates an increase in heart rate, increase in blood pressure, and sympathetic activation, which results in peripheral vasoconstriction. So what happens is that PAT signal that's looking at the pulse arterial tonometry is analyzed with the pulse rate and the oximetry, and that will give us the sleep apnea indices. The accuracy, if we look versus full PSG, is more than 88% accurate for the RDI, 89% for the AHI, and over 94% for the ODI. So really quite accurate. And certainly accurate enough if we're looking for moderate to severe apnea. If you're 10% out on an AHI of 50 per hour, it's really not going to make a difference to the diagnosis or to the treatment that you go with. So what's also important about the PAT is that it measures sleep stages. And so it looks at the PAT signal, looks at changes in heart rate and pulse volume. So we know, for example, in REM sleep, there is an increase in heart rate variability. And so it can actually give you sleep stages, which can really be important. So this is the kind of data that we get from the WatchPat. This is a case of severe apnea. So there's lots of blue lines up here. So this is an isolated apnea occurring here. This is an apnea index. So here is the PAHI. The AHI here is 81 per hour. This is what 81 per hour looks like on the respiratory channels. The orange here is the snoring, so this is severe snoring. The black line indicates body position, so we can see on the right side, supine, then to the left, back to supine. And that's really critical in some patients to diagnose positional apnea, which is obviously a much easier treatment solution than CPAP. The black line here indicates oxygen saturation, and you can see the typical very rapid drop in oxygen saturation and very rapid return of oxygen saturation that occurs with sleep apnea, with each individual apnea. The pulse rate is here in the red, and here are the sleep stages with REM with the red lines and light sleep here. This patient has no deep sleep whatsoever. The watchpad can also give us central events, which may be important in patients. So it does give us a Cheyne-Stokes respiration percentage of the night, as well as the central apnea. So central apnea here of 34 per hour as part of this AHI. So the AHI includes the central apneas, and so the obstructive amount here would be 56 per hour. So this is the kind of report that we get from the watchpad. It also gives us other indices. So other indices which may be important, I've spoken about positional apnea. So here we have, if we look at the apneas, we can see clear clumping of the apneas during the night. And if we track down through the different channels, we can see that the apneas occur mainly when the patient is lying supine. You can see the desaturations occurring in the supine position and during REM. So you can see that this is clearly a REM and a supine problem. And as you go through the night, you can see everywhere that there is REM sleep and the patient is lying supine, you are likely to get apneas. And so this would give what this would look like is, if you look at the results, it would say something like the AHI is 25 for the night, but when the patient is in REM sleep, that goes up to 40. And when the patient is lying supine, that also goes up to 40. So identifying what happens to the AHI during REM sleep and what happens when the patient is lying supine can be really important for treatment purposes as well as cardiovascular health. What you can also see on the watchpad is you can see cardiac arrhythmias. So this is a patient who has severe apnea. And if we look at the pulse rate here, this is a pattern that's very typical of atrial fibrillation that's occurring. We do a lot of home studies for the cardiologists with the patients who have atrial fibrillation to do screening for sleep apnea because of the very close relationship between atrial fibrillation and obstructive sleep apnea. So we can see quite a lot of information from the watchpad, and it gives us a lot of extra information that can be useful. So the sleep stages on the watchpad, I mean, people always ask me, like, how accurate are they? Can we actually use them? Do they make sense? The watchpad is the only FDA cleared, so non-EEG device that reliably measures total sleep time. Most of the home studies do only look at total recording time rather than total sleep time. And the REM and being able to find REM sleep, as I mentioned, is important because we can see significantly greater oxygen desaturation occurring in REM sleep. And so if you see that very low saturation that occurs in REM sleep, that indicates a much worse scenario than just the overall ODI. And so it is using a lot of the amplitudes in the peripheral arterial tone, interpulse periods, the pulse rate variability, and shows moderate agreement in sleep stages in normal subjects and in sleep apnea patients. So it can be used. It's obviously not 100% because it cannot measure the same as the EEG does, but it's reasonably accurate and accurate enough in patients who have moderate to severe sleep apnea, which are the patients who are going to be monitored on this device. So sometimes the desaturations are enough. So if you have severe apnea, it doesn't matter what the sleep stages are, because I can tell you that this little patch here that you see right here, I can tell you that that is REM sleep, because that is what REM sleep looks like, is this massive desaturation, really much worse desaturation than you get through the rest of the night. So this is sleep apnea. There is nothing else in the respiratory system that creates this type of desaturation. Anything else that is looking at lung or or pulmonary kind of disorders is going to show a drop in the entire baseline of the saturation, not this kind of comb effect, this very rapid up and down in the saturations. So if we look at the causes of sleep apnea, it's really important that we're talking about the area of the pharynx here, which is designed to close with swallowing, with the closure of the palate, the closure of the epiglottis, and then the tongue moving backwards. It's designed to close with swallowing, but should not close with breathing in. And sleep apnea, snoring occurs because of a partial obstruction. So any fixed obstruction in the way, a deviated septum, enlarged adenoids, enlarged tonsils, lying on the back so that the jaw moves backwards, putting on weight so that the entire airway is narrowed. Anything like that produces a partial obstruction, turbulent airflow, and the palate then vibrates and creates the noise. Apnea occurs when all of that gets worse, and that on inspiration, the inspiratory pressure that's required to move 500 mils of air approximately every breath, the inspiratory pressure that's required actually causes a collapse in the airway, and a very passive collapse in the airway, and the airway closes. Then there's no movement of air, snoring stops, there is a very clear pause in breathing, and then there is an awakening to open the muscles, the dilator muscles of the pharynx, open those muscles up and restart breathing again. The muscle tone of this area is extremely important and is often ignored in looking for a cause for snoring and apnea. And that occurs with aging. It's the reason why, for example, some medications can work to treat sleep apnea. It's the reason why cannabis works to treat sleep apnea, is improving the muscle tone in the pharynx. So if we look at a typical obstructive sleep apnea, here is the loss of airflow here. Here is the muscle, the respiratory effort that's occurring at the chest, respiratory effort at the abdomen, and then there are two main components that we look at when it comes to what are the consequences of apnea. One is the arousal from sleep, which often creates the daytime sleepiness, and the other one is the desaturation, as I've mentioned, because there are significant desaturations with sleep apnea. Why it's important is if we put everything together, so this is a beat-by-beat blood pressure measurement with apneas. At the top, we have the saturation. Here is the patient going to sleep, so the saturation sitting at 90. Here are the massive swings that we get in saturation with each apnea. The apneas are here at the bottom. There is airflow, there is chest wall, and you can see the relief of apnea and the rebreathing and the apnea and the rebreathing. So as the apnea starts, there is a drop in saturation, which reaches its minimum as the patient has an arousal. With the opening of the airway, the saturation very quickly comes up to normal. This is a very unique situation, and on this research study, they measured beat-by-beat blood pressure. And what is really significant is with that arousal, with the increase in adrenaline, the increase in blood pressure that happens, which settles very rapidly, and then increases again with the next end of apnea, and so on and so on. So there is this constant swinging of blood pressure that's occurring. What's important pathophysiologically then is that increase in blood pressure, which is produced by an increase in cardiac output, increase in cardiac work, occurs at exactly the point where the hypoxia is the most. And that's hypoxia within the cardiac system as well. So you have a heart that is hypoxic, that is now beating faster, higher cardiac output, and that is never a good combination. So what it means in the long term is that you can create hypertension, sustained hypertension, after 3 weeks with experimental sleep apnea in animal models. There is in humans, a sustained high sympathetic tone during the day. There's a lack of nocturnal dipping of blood pressure during sleep, which is obviously that's not happening anymore because of the increase in blood pressure with the apneas. There can be intermittent hypertension. So often patients will say, my doctor thinks I have hypertension, but we're not sure because it's not always high. Blood pressure is often high in the morning, but lower in the afternoon. And if you do have a patient with hypertension and you don't know that it's based in obstructive sleep apnea, the mechanism is unexpected. So the mechanism of hypertension in sleep apnea is not is not through the renin-angiotensin system, but more the sympathetic system. And so they often do fit into that class of resistant hypertension, because unless you treat the sleep apnea, it's very difficult to treat the hypertension. When it comes to arrhythmias, you've got a combination of hypoxia, as mentioned. You've got the sympathovagal imbalance, particularly an increased sympathetic tone. But what you also have is in the actual chest itself, the chest cavity, because there's been an obstruction to flow and because there's continued respiratory effort, there is a stretching of the heart that's occurring. So a stretching of the heart and then an increased pulse rate and an increased blood pressure with hypoxia and systemic inflammation. None of those are good, and all of them together is a bad idea. So they're very good evidence of the relationship between sleep apnea and atrial fibrillation. Patients with sleep apnea, these are just two of the studies. Patients with sleep apnea 4 times more likely to have atrial fibrillation. And if you have sleep apnea and atrial fibrillation and you go have a cardiac ablation, the success rate of the cardiac ablation is halved. But if you're on CPAP, if you know you have sleep apnea and you're on CPAP, then you have a better treatment effect with cardiac ablation. So that's why the cardiologists, and some of the cardiologists in South Africa, not all of them, unfortunately, send patients for a sleep apnea test before they have a cardiac ablation, because they know that if their patient has sleep apnea and goes on CPAP and they then require a cardiac ablation, that the success rate of that cardiac ablation is significantly improved. Oh, sorry, I've gone the wrong way. So the effects of sleep apnea on cardiac disease, on any kind of disease, is through exactly the same pathways as cardiac disease itself. So inflammation, increasing adipokine pathways, endothelial dysfunction, hypertension, dyslipidemia, it's the same pathway. So when I speak to patients, I say what sleep apnea does is just push you faster towards a cardiovascular disease. It doesn't create it on its own. It just makes everything happen a lot faster. And if you do treat with CPAP, it does reverse some of those effects. So reverses the endothelial dysfunction, reverses the inflammation and adipokine effect. So the American Heart Association is moving closer and closer to a point where it recommends screening for sleep apnea in everybody. So these are the screening. I think it's 2020, or 2019. So it's certainly most recent one. Is that all of these patients should always be screened for sleep apnea, and that's resistant, poorly controlled hypertension, pulmonary hypertension, and recurrent atrial fibrillation, either after cardioversion or ablation. So if those procedures don't work, patients should always be screened for sleep apnea. Then there's another group of patients that you should, if you find any signs or symptoms of sleep apnea, that then you should do a sleep study, and that's kind of pretty much every. The long-term effects, if we look at, this is just one of the studies. There are studies that show there's no effects. This is one of the studies that shows significant effects. So the top graph looks at fatal cardiovascular events over a 12-year period, so 144 months. Over a 12-year period, fatal cardiovascular events, the one below shows non-fatal cardiovascular events. And it's quite clear that those patients with severe apnea have a significantly higher risk of both fatal and non-fatal cardiovascular events, and that effect is reversed if the patient is treated with CPAP. So the risk of the cardiovascular events goes back to those patients who have mild apnea, which is not significantly increased versus against controls and snorers. There's also quite a clear relationship between sleep apnea and diabetes. These two graphs are in two halves. So the first half, the left-hand half of each graph, shows the sleep apnea prevalence with increasing BMI. And what it shows particularly importantly is that the relationship in males between sleep apnea and BMI is quite profound, and it's not as profound in females. So in males, it goes up quite quickly. So what the easy number to remember is if you have a BMI over 40, the chance of having sleep apnea is at 40%. However, in women with a BMI over 40, the risk of having sleep apnea is still sitting below 20%. And this is possibly why in men, weight loss has a more significant effect on sleep apnea than it does in women. However, If men or women have type 2 diabetes, the prevalence is about the same. So these are 3 studies that looked at sleep apnea prevalence in type 2 diabetes and show that when you normalize for BMI, the prevalence of sleep apnea is higher in patients with type 2 diabetes, and in women the prevalence is exactly the same in men. So prevalence is high in type 2 diabetes, and all patients with type 2 diabetes should be asked about snoring and sleep apnea. Other consequences that you might get from sleep apnea, I've given up trying to find a system that is not affected. So if you are a male patient in middle age and you present with depression and you have sleep apnea, those depressive episodes are likely to be worse, more likely to be treatment resistant. Patients who have sleep apnea are likely to have low testosterone and lowered libido. We have a clinic that is a testosterone clinic and looks at male impotence, and they screen pretty much all of their patients for sleep apnea and send those that have some symptoms, they would send them for a screening test. Polycythemia can occur in patients with severe apnea. You can understand that low nocturnal oxygen saturation can trigger increased production of red cells. I get patients from an ophthalmologist close to me who sends them with a letter that says they have floppy eyelid syndrome and red eyes, and please would you screen for sleep apnea? And I thought I didn't understand this at all, but it was described in 1997 as having an association. I have no idea how it's associated, but it just is. Liver disease, sleep apnea is an established risk factor for non-alcoholic fatty liver disease because of the dyslipidemia, because of the movement of lipids that's occurring at night. And then end-stage kidney disease because of fluid movement. It's estimated up to 60% of patients have sleep apnea. So it's very common. Sleep apnea is very common in other disorders. And so we need to be looking for it as a comorbidity and as not just a comorbidity that it co-occurs, but that when it is present in these other disorders, it is making those disorders worse and harder to treat. So pulling back on the apnea is likely to make those disorders easier to treat. The effects of nasal CPAP, this is a systematic review that was done by the American Academy of Sleep Medicine in 2019, that nasal CPAP causes a significant reduction in disease severity, daytime sleepiness, blood pressure, motor vehicle accidents, and improvement in sleep-related quality of life in adults. The problem is with the RCTs is trying to do RCTs on other cardiac risk. It's not clear. There's some studies that show clear results and some studies that don't. What is important is that the initiation of CPAP in the home is just as good as an in-laboratory titration. We do home studies. We also do home CPAP titrations. Roughly our success rate is 90 to 95%. We send patients home for 3 nights with different masks to try. They have 3 nights to try the CPAP. They often say, can I have another night to see if it works or not? And we can do that. Whether you use an auto-adjusting CPAP machine or a bi-level CPAP, and both of those are obviously much more expensive than the standard continuous CPAP, so what we'd call the fixed pressure device, there's no difference in clinical outcomes. And so patients do not need to buy the Mercedes. They can do quite well on the Volkswagen Golf. So there are problems with this data, and that there are very few studies on women. There's a difference in the severity of sleep apnea that's used in the different study. And there are very few studies on patients, for example, who start with depression. What is the sleep apnea relevance? If we treat the sleep apnea, what happens to the depression after that? So very few there's studies looking at sleep apnea, depressive symptoms in sleep apnea, treat the sleep apnea, what happens to the depressive symptoms, but not if you start from a position of depression and all the other comorbidities. So there's very few studies on those, but more are being done, and so we expect the data to change. So if we look at CPAP and heart failure, so we've spoken about CPAP and atrial fibrillation definitely has an effect. CPAP and general cardiac disease, there's an effect. The problem with heart failure is that there is an increased risk of sleep apnea, but there's also an increased risk of central sleep apnea and Cheyne-Stokes respiration. Now, what is clear is that CPAP does alleviate symptoms of heart failure. It does improve left ventricular function and oxygenation. And to a certain extent, it will abolish the central events in patients with chronic heart failure. But there are some studies that have shown that in patients, particularly with the central events, if you use CPAP, particularly if you go up the CPAP ladder, so there's CPAP, which is continuous positive airway pressure. There's bi-level devices, which have a set pressure at inspiration and a lower pressure at expiration. So those two pressures are set, they're not continuous. If you move into the ASVs, which is the adjusted servo ventilation, which acts as a mini ventilator, and if there is a central apnea, will trigger a patient breath. There are some studies to show that patients do worse on those kind of ventilators, which are often needed to manage the central apneas. And so the data is not clear as to whether we should go that far and whether that might actually improve patient outcomes. So in conclusion, sleep apnea is much more common than you think. If you think that the general population in Mauritius, there's a 26% risk, the patients that come to see you have a higher risk than that. They're more likely to have sleep apnea. It is the worst comorbidity because unless you ask, you won't know. It is not the patient's job to link sleep apnea and their snoring to their cardiac disease or their pulmonary disease. You have to ask. It happens at night when you don't see them. We do get quite a few patients that are admitted for something else. The next morning, when the doctor goes around to see them, the pulmonologist or the cardiologist, the entire ward is complaining because they snored so badly, and we get asked to do a hospital study the next night. And the patients don't even know it's happening. So if you have patients who's single, who doesn't have a bed partner, they may have no idea that it's happening. What is important is bed partners do. I'm always very clear when I get patients who come to see me with their wives. I know what the problem is because they're coming because the wives are convinced they won't actually tell me exactly what is happening. Certainly, when it comes to patients with type 2 diabetes and cardiovascular disease, questions about sleep should be standard in that assessment. And the question is really easy. Do you snore? That's it. That's what you start with. And then if they say, yes, that I snore, pull out the stop bang. It's readily available everywhere, or the Berlin questionnaire. Pull that out, get them to answer that. If they're 4 or 5 out of 8, then consider doing the sleep test. And the consequences of obstructive sleep apnea, it's now very clear, are much more than just the effect on the daytime function, which is fatigue, sleepiness, lack of concentration, motor vehicle accidents. Patients with obstructive sleep apnea are 8 times more likely to have motor vehicle accidents than patients without apnea. So the consequences are much more than just what the patient is experiencing. There are these long-term consequences of cardiovascular disease and metabolic disease. So what I can tell you is that what I've given you now is like 45 minutes of sleep apnea. There are 6 lectures on sleep apnea on the Sleep Society website. You just need to be a member and you're welcome to have access to those. There's a lot more about managing sleep apnea, so a lot more on CPAP, a lot more on snoring and mild apnea, as well as other disorders which may mimic the symptoms. So you're most welcome to be a member. It's just 200 Rand, and then you can get access to the course online. Unfortunately, it's all taught by me, so you will just have to listen to me for 6 hours, but hope that might help, because I do know there's a lack of training on sleep apnea generally. So thank you very much for listening. That is the end of my presentation, and I'm really happy to answer any questions that you might have. Even if I answer them with I don't know, I'm really happy to answer the questions.
Thank you so much, Dr. Bentley. It's very enriching presentation, and of course, we are not so much familiar with this pathology. So many things need to be acquired, to be learned, and very very true that you said that we can access the trainings through the site. So and you showed in your last slide. So hopefully maybe we can join the sites and then learn more about the disease. So we have one question from the floor. So yes.
Thank you, doctor, for the nice expose which you have given. Basically, I am an ENT surgeon. My name is Dr. Tina Singh. And so I do a lot of surgeries related to sleep apnea. And I've been doing that for the past 15 to 20 years now. And most of, like you said, obstructive, like we say, we are related to the nose and the tonsils, even the adenoids, like you said, all that. But there are two conditions which I have really amazed. I'm planning to write an article about that also. One is if a patient was operated on his nose, he had a roomy cavity, completely like the turbinate was excised, and it was like the patient was not, he has undergone also tonsillectomy, but he's not able to, he's still having that apnea. And he said he cannot sleep, he has to sit down and sleep. This is one case which I am coming across for him, what I did also. I tried because mostly it is related to atrophic. And so what I thought, like, you know, I did it's called as the grafting of the fat into the nose. That also I tried to give him some, to reduce that, the atrophy. So this is that air which is breathing, maybe that is one of the causing, and the airflow, maybe that was another causing the apnea. And the second patient which I had was from Seychelles. She had a tonsils and she had also a deviation. I did both the surgeries. After the surgery, but still she was having that. Then I did a scan. I saw the retrosternal goiter really changing the shape of the whole trachea.
Mm-hmm.
So I had to take out the whole thyroid completely. And then finally she was completely relieved. Now she's very happy. She's fine. But these are the things quite strange which I've come across. That's something to share if you have got anything to say about it. Thank you.
Yeah, no, thank you for that. I appreciate those cases. Certainly, when it comes to the causes of sleep apnea, there are ENT problems. Obviously, I mean, a lot of people who have sleep apnea do have nasal pathology, tonsils, adenoids, particularly in children. So, I mean, taking out tonsils and adenoids in children, 95% chance you're going to solve the sleep apnea. But I think there's a line over which there become the actual muscle tone in the pharynx becomes a problem, and then doesn't restore. And so you have a very floppy kind of pharynx. And even if you take out the obstruction, there's still a problem with that. It also can be positional apnea. So the ENT, so when I talk to patients and doctors and I say, what are the causes of sleep apnea? I go, ENT, obviously that is a cause, but it's not the only one. So weight gain is a cause. So being overweight is a cause. The jaw, it can be a problem if in positional apnea. So many patients, all the muscles that control the jaw relax when you're asleep. And so you have a mobile jaw. And so lying on your back, particularly, that jaw can hinge backwards and become the obstruction on its own without anything else happening. So the jaw can be a problem. Gastroesophageal reflux can be a problem at night. So we do have patients who have got mild apnea, and we just give them what my ENT colleague in Cape Town would call his anti-reflux therapy, which is at least 3 hours between dinner time and bedtime, and to take a mild antacid before you go to sleep, and shows significant differences in apnea. So gastroesophageal reflux can be an issue. And then so can positional therapy. So just body position can make a massive difference to the apnea that is there. And then muscle tone. I mean, I think we underestimate the muscle tone component of apneas, but it's certainly the reason why speech therapy works for apnea. So there are a couple of papers to show that if you do exercises for the base of the tongue and the pharynx in general, that you do get some resolution of apnea in a significant number of patients. It's also the only angle for which the medications could work for sleep apnea. So there's data to show that dronabinol, which is one of the cannabinoids, improves sleep apnea. I have a number of patients who tell me that if they do smoke dagga at night, that the pressure that they require on their CPAP is significantly dropped by 2 or 3 centimeters of water. Those patients are on auto devices. And there's also a number of papers to show that Strattera, so atomoxetine and ditropan, which is a bladder muscle relaxant, together can cause a significant drop in apnea. Now, they can't do anything to a fixed obstruction. They have to be working on the muscle tone that's actually in the throat. So it's certainly true that you can get significant resolution of apnea with ENT, with relief of ENT obstruction. But in those patients where you don't get relief, it may be one of those other factors. And so those are the patients who need a good sleep study to kind of go, is it positional? Is it maybe a jaw thing? Or is it actually that they have more severe apnea? And the data we have about ENT surgery for moderate to severe apnea is it doesn't work as well as in those patients who have mild sleep apnea. And so the ENT surgery may be solving part of the problem, but not the whole problem. And those patients may still need to go on CPAP. Hope that answers that question.
Yeah, I think Dr. Tina Singh is happy with your answer. So,
because I can't see him.
Thank you. We've got one more question.
Along the same lines of muscle tone, relaxation, and improvement of apnea, I'd like to know your thoughts on, let's just say, patients who haven't yet been diagnosed with sleep apnea and feel they've got bad sleep, and they get prescribed benzodiazepines to improve their sleep. What's your explanation in terms of mechanism? I think it needs to be mentioned.
Yeah, that's a controversial one. That's a controversial one. So there are patients who have mild sleep apnea and who fit in that insomnia group. So, and I mean, so what it seems to be that what you present with when you have sleep apnea depends on your biological respiratory arousal threshold. So if you have a low threshold, every little respiratory event is going to interfere with sleep and you're likely to present with insomnia. The higher the threshold is, the more likely you are to present with nothing because it actually doesn't interfere with sleep. And we don't know how that works, but that is how it works. So what benzodiazepines would tend to do in patients with mild apnea, and particularly those who are suffering with insomnia, is reduce the effect of the arousals, actually create a high respiratory arousal threshold and allow them to sleep better. So patients do say that they sleep, a number of patients with apnea say that they sleep better. The concern with benzodiazepines, as it is with anesthetics, in fact, is that what is ending the apnea is an arousal from sleep. And if you dampen the ability for the brain to wake up and restart breathing, you potentially lengthen the apneas so that they go on for longer and the desaturations get worse with sleeping tablets or benzodiazepines of any sort. It's not, so it's kind of contraindicated because we don't know what it's going to do to the apnea. Very few studies have been done on, okay, here's this patient and we give them a benzo, a sleeping tablet, what happens at night? So it's not a consistent effect, but kind of just feels wrong to dampen down the arousal response in patients where the arousal essentially is saving their life 100 times a night.
Thank you very much for a nice expose. I've been using the WatchPad device for quite some time, for many years, and I'm a cardiologist, and we've been doing the screening for the sleep apnea. But the problem that I've faced is that people don't like to comply with the CPAP.
No, they don't.
It's a huge issue, especially young patients.
Yeah.
Young patients, I mean, even if they purchased it, are not using it. And in my practice, many have done the sleep study. They've been diagnosed with severe sleep apnea, but at least 50 to 60% of the patients are not using it routinely. So that's the challenge, which I think is like how to improve compliance, and are there better devices that. So much so that one patient told me, "Doctor, you use it on yourself and then tell me."
Yeah. I think, no, you're absolutely right. I mean, no one is designed to sleep with a thing on their face. They're just not. And particularly patients who maybe don't have a lot of symptoms, might have severe apnea, not many symptoms, and they kind of feel that the treatment is worse than the disorder itself. So there's no question. What we find is that often patients come for the CPAP titration. So they'll do the titration, have a successful titration, and then don't get the CPAP machine. So that's where we find the gap is. And that's where we need to start getting smart with other treatment options. So there are other treatment options. So for example, there's just been a study come out showing that one of the GLP-1 inhibitors has significantly reduces sleep apnea. So we know that weight loss works. It's very hard to lose weight if you have sleep apnea, partly because of the fatigue that you have during the day, partly because of the changes in metabolism that are happening. What we don't have are good studies to show if we combine a whole lot of treatment options, which are maybe easier for patients, so such as positional therapy, plus weight loss, plus a mandibular device, so a mandibular advancement device. If we combine those, can we reduce the apneas maybe from 40 apneas an hour down to 15 apneas an hour, which is maybe not ideal, but is better than them not using CPAP and still sitting at 40. So we don't have a lot of studies with good combinations of the treatments that we would usually use for mild sleep apnea. And that's actually what we need, particularly in a situation. So in South Africa, sleep medicine is really at the moment restricted to private healthcare. There is no sleep medicine happening in the public sector, and our Department of Health is never going to pay for CPAP machines for patients. If you think about 23% of our population, our adult population is likely to have sleep apnea. That is billions of rand spent on CPAP machines. And while I understand the CPAP suppliers would love that, it's just never going to be put in the budget. So we have to find alternatives for treatment, and that's where we need these other options, to try these other options. I've also found, I've got a number of cases, and I want to do a more detailed investigation of young patients. So when we see a young patient who has severe apnea, they never started with severe apnea, they actually started with mild apnea. And there's been a gradual degradation in the apnea so that now they have severe apnea. I've had 2 patients who are young, in their 40s, who have had severe apnea. We have put them onto CPAP. They have used CPAP for 3 to 6 months. They have then come off CPAP, and one of them lost 10 kilos. The other one did the anti-reflux therapy thing with a steroid nasal spray, and both of them have no apnea. So their apnea is treated in a sense because they have brought in these procedures. So I think they're a group of patients that if we could persuade them to stay on CPAP for 3 to 6 months, then take them off, that they are now mild, and then these other kind of treatments are likely to work. So I think we do need to look at alternative treatments. I agree, CPAP is not great, particularly not great as a lifetime thing for young patients, like for the rest of your life, for the next 40 years, you're going to have to be on CPAP. And we do have to come up with alternative therapies. I absolutely agree with you.
No, like, is this like IVs, they tell them to use it for a few hours and then remove it and sleep?
Yeah, I mean, look, compliance to CPAP is not a full 8 hours. Compliance is considered to be 4 hours a night.
Yeah.
Yeah,
And,
so
and you were mentioning about titration. So the CPAP, so like what exactly you do when they come for the CPAP titrations?
So what we do is we give them an auto device. So an auto, I use the Philips Dream Station because I want lots of data. I want to really know what's happening at night. And so we give them the Dream Station. They come in for an appointment. We look at the masks. So we try different masks on them. We put the machine on, show them what it feels like to breathe with the CPAP, show them how the machine works. And then we send them home and they use it for 3 nights. And then they bring it back. We get a really good download from the device, which shows us really what's happening every night. We can see the pressure. And then we say, then it's a point of do they want to purchase a CPAP machine? And as I said, that's where we get the fallout. So for me, the CPAP titration is hugely important because I tell the patients, Why you're doing the CPAP titration is so that you can make an informed choice afterwards. Do you want to continue? Do you not want to continue? You can try the different masks. You can try the machine out. Does it make a big difference to your daytime function? And patients fit into different categories. So we have some patients who take the CPAP machine home, come back, kind of hand it over to JJ because he's waiting for that machine, hand it over to my staff and go, I'm not giving you this machine unless I can take one home because it has made profoundly changed my life. So we have those patients, and we have those patients who drop off the machine and we never hear from them again because they're going, I'm not doing that. Even though the titration has been successful, even though they've managed to sleep for over 6 hours every night, even though the AHI has gone from 60 to 5, even that it's worked beautifully, they still do not want to go on CPAP. And we don't know why. We don't know why they've made that decision not to go on CPAP. I suspect because they kind of go, I don't want to do it. I know it works, but I don't want to do it.
Thank you very much.
Thank you for these clarifications. Do we have any other questions now?
Nope.
Sorry.
Hi, good evening. I'm Dr. Murphy from the I just wanted to ask a question about positional sleep apnea. You mentioned that people sleeping supine sometimes will only have it when they're on their back or that sort of thing. For these people, is it worth them wearing a CPAP machine, or is there a way to find a technique to make them not go into that position, and would that be enough? I mean, I don't know how you control that in sleep, but are there tricks that you come across?
So I missed the first part of that. Are you talking about gestational sleep apnea? So sleep apnea while pregnant?
Positional sleep apnea.
Oh, positional. Oh, positional. Oh, okay. Yes. Sorry.
In a position,
Yeah,
do
yeah,
they
yeah.
need to wear CPAP, or can they
Yeah.
just sleep in a different position?
So it really depends on how the numbers work. So there's a whole bunch of criteria. So there are patients that if you kept them off their back, so the positional is usually supine. That's where the apneas can tend to concentrate. So there are patients, and so what we get on the watch pad is we get what is the AHI when they're lying supine, what is the AHI for non-supine. And there are patients who we can say, here is the AHI supine. If they were non-supine for the whole night, then the AHI would be 5. Then we know that positional apnea on its own is a good treatment. And so there's a lot of different ways of doing it. And there's data on all of these things. So the main way that I use to say to patients, let's try to see if this works at all, to see if keeping you off your back improves things. And so I would tell them, so there's a thing called the tennis ball technique. And that is that you sew a little pocket into whatever you wear in the middle of your back between your shoulder blades. And you either put a golf ball or a squash ball or a tennis ball in that pocket so that if you lie on your left-hand side and you turn over onto your back, it's uncomfortable and you just keep moving. There's research on that, okay? And that shows it works. Or else you take a practice golf ball, which has got holes in it, and tie it, just sew it to the back of whatever you're wearing. There is a training that occurs over a couple of weeks, and patients will say, I don't have to use it anymore. My body's now learned not to lie on the back. And so they tend to lie on the sides. So it does work. And just doing that, the data would say that sleep is maintained, that the AHI drops to whatever the non-supine AHI is going to be. Philips does produce, and there's a number of pillows that you can use. So there's a pillow called a Sona, and it's kind of it's structured like this so that if you sleep on your back, you're sleeping on the top of a mountain. But if you sleep on one side, you're sleeping on that side of the pillow or that side of the pillow. So the pillow just kind of rolls you from one side to another, but it's extremely difficult to lie on your back. Philips produces a device like a band around your chest, which will vibrate if you're on your back and shift you off on your back. So there's a number of ways of implementing positional therapy, and some patients prefer it much more than CPAP. Does that answer the question?
Yes, thank you.
Thank you. So, any other questions? No? Okay, so thank you very much for this presentation and so much of clarification. Now our view towards obstructive sleep apnea has changed. It's not just with CPAP, but of course different modalities to treat it, and of course to look at it from the other perspectives of the other comorbidities associated with sleep apnea. So thank you very much, Dr. Bentley, for
It's a
this
great pleasure.
for the presentation. And
Good night.
Good night, and thank you very much.